As we progress with our evening, I've got to stop to tell you that, as many of you know, goodness gracious, 30 years ago, I bought Dr. Bill Lockhart's practice, and this is Bill. And he just taught me so much about life and about dentistry and about just being the best you can be. And this is one of the things you talked to me about, equilibration. You know, it's not that hard. Get the crap out of the way that you don't want to touch, and centric relation will find itself. As many of you might know, Bill passed away here just a few weeks ago. And I got to tell you, he's one of the founding cadre members of the Pankey Institute. Without him, the Institute wouldn't be what it is today, and I sure wouldn't be who I am. So, Bill, we're thinking of you, and I miss you a bunch. So I had to mention that. This is me. I'm in private practice. I do my thing every day. I have my finger stuck in somebody's mouth. That's how I make my living. I do have a background as a lab tech. I do my thing at the Institute. Everything I'm going to show you here, nothing's made up for lecture. It is what it is. And I think this last thing that you see here is really important. Some of my dentistry sucks. I think it's really important to understand that. It's not always perfect by any means, but boy, we sure keep trying, that's for sure. So that's a little bit about me. Let's take a look at this lady. She's an elderly lady, and she presented, and her primary concern was aesthetics. And it's interesting that when I look at this, you know, I want to get in my mind's eye, how should we restore it? And so if you can envision this old central incisor here, assuming that this incisal edge is about the right place, one of the things I can do is look at the width of this tooth, and I want the length of it about 25% longer than the width. So that's my first rule of thumb to help me establish where should this incisal edge go. So maybe it should be a little bit longer, but if I do that, envision this tooth would obviously need to be built up, as with this, as with this, as with these. The lower anteriors, you can see here, she's got a lot of heavy wear from her deep bite. So if I lengthen all of these, I have no choice but to open vertical dimension, because otherwise, if I got the lower anteriors, these teeth, to a correct height, it would require me opening vertical. So this is one of the reasons that we will alter vertical dimension. We'll do it because aesthetically, we need to get the appropriate proportion of tooth. Now, I did this case, goodness gracious, it was probably 15 years ago, and I literally just built all of this up with composite. Now, today I would do it with my composite overlay technique that we talked about during our last webinar. Back then, that wasn't on my radar, but regardless, this tooth had a root left. I put pins in it. This is all composite. I left this crown alone. I just did composite bonding along here to get my incisal plane. And obviously, as I created the lower anterior incisal plane, it necessitated that I open vertical dimension. So the question becomes, if we do that, what are the ramifications of that? Is it okay? Because for some reason, we've got in our mind's eye that if we alter vertical dimension just that much, you might kill somebody. And as what I'm going to tell you is it's just probably not true. We've got definitely some variability in terms of what we can do vertically. And so we're going to talk about that just a little bit. This is a case where I've got somebody that is obviously class 3. Notice the difference in the plane of occlusion. I've got a lower anterior segment that is super erupted. The lower posterior section is on a lower plane. As that has occurred, the canines of the maxillary have super erupted, and the incisors, the centrals and laterals of the upper, are shorter. So we've got uneven occlusal planes. If I'm going to give us appropriate tooth length here, once again, I have to open vertical. So I did a wax up. I made stents. I put bisacryl in the stents. I seat that. And this is a mock-up of what it could be like if we open the vertical dimension. So once again, we will use that to our benefit to help us get appropriate tooth proportion and even to help us in terms of occlusal stability, et cetera. Now, the reality is that if I'm going to do this, I'm committed now to restoring at least one full arch. When I alter vertical dimension, because I open the interproximal space, now I've got to restore at least one full arch. So one of the dilemmas when we alter vertical dimension is that it really, really forces us to do a lot of dentistry. Now, I can't go into this much more until we solidify global diagnosis. And we've talked about this many times before. This is not my deal. This was developed by Dr. Bill Robbins and Jeff Rouse. And I mention it because one of the first things we do in global diagnosis is we look at proportions in repose. We're going from glabella to the base of the nose, or the base of the nose to the bottom of the chin. And ideally, this ratio should be about 1:1. We go further, we look at the upper lip, we break that down from the base of the nose to the bottom of the lower lip, and there's a length that it should be. And then we start to look at tooth proportion. And we understand that in an ideal situation, there's a length to width ratio of the tooth. So I always start by looking at the width of the tooth, and I know that I want the length to be about 25% longer. So in this scenario, where I've got short clinical crowns, we go through the process of getting the Explorer out, asking, do I feel a CEJ? If we don't, we have a short crown, no CEJ. We understand we have altered passive eruption. In that scenario, we refer them to the periodontist. They do aesthetic crown lengthening. Here she is 6 weeks post-op. Here she is before and after, thanks to Dr. Robbins. And then the other consideration that we have is dental alveolar extrusion. So in this scenario, I've got a short clinical crown again, because it's what's happened is as these teeth have worn, they've super erupted. As they super erupt, the gum follows it down. So I end up with a short clinical crown, but notice I don't have level free gingival margin heights. So in this scenario, the difference is instead of aesthetic crown lengthening, we're going to go in orthodontically and we're going to intrude the teeth until we get a free gingival margin level that is even. Now that this is level on the free gingival margin area, I will then lengthen the teeth as needed, whether that's with bonding, whether it's with veneers, whatever you might choose to do. Now, the next step in global diagnosis is that we're looking at that facial dimension from glabella to the base of the nose, bottom of the chin. I mention that because this can be our first clue as to whether we have a vertical dimension of occlusion problem. If that's not 1:1, that immediately raises a red flag to me. Now, in this case, is what we have is vertical maxillary excess. So we understand it's a skeletal discrepancy issue, and we would need to treat that accordingly. So we're going to keep that in mind as we go through the 5 questions that Dr. Rouse and Dr. Robbins taught us. So keep that in mind, because we'll even utilize that to help us with some of the vertical dimension considerations. Now, I would tell you that one of the things that I am problemed with as I deal with dentistry every day is the fact that all so often we get caught treating teeth and we're not looking at the big picture. And I'm going to challenge you to really back up and quit looking at teeth and look at the entire system. Of course, part of that system that we have to look at is vertical dimension. For those of you that have heard me speak before, I want to refresh a diagnostic sequence that we teach at the Institute, and it's called the Pankey Restorative sequence. And in it, the first thing we do in the lab is we start with working on diagnostic study models. And we've got to understand how to sequence working on those diagnostic models so that we can get it developed in terms of what do we want to do in the mouth. So I want to go through that sequence because there's some really important parts to that we have to consider in regards to vertical dimension. The first is this. The first thing we do is we look at the global diagnosis and we ask, is there any component of that needs to be addressed? So here you see somebody preoperatively. They've got short clinical crowns. The incisal edge is in about the correct place. She's got a little bit of a deep bite with some heavy wear. In this case, she's actually got a lateral with a free gingival margin that's up much higher. So this could be a case where orthodontically, I might choose to extrude this lateral incisor to get the gum levels more level. But the point is, I start by considering any of the global diagnosis considerations and treat those as needed. Now, the next step is I've got to manage the TMJs and the airway. And in doing that, I'm going to get models mounted to centric relation. So we typically have two sets of models that we mount. And I understand that when we're talking about centric relation, I've got where the condyle fits in the joint space. That is going to be affected by how the teeth fit together and also by the force that the muscles put on everything. So keeping that in mind, I want to review just a few fundamental things that I think are really, really critical. When we talk about lever systems, this is a class 1 lever. It is the most powerful lever that there is. So you can give a pair of pliers to somebody that cannot generate a lot of force, and they can put that pair of pliers on your ears and put a little squeeze on those pair of pliers, and it's going to hurt, because this is a very powerful lever. Now, the next lever is a class 2 lever. Be like a wheelbarrow. Here you have a fulcrum, you have a force that is out here, and the work is done in the middle. It is not as strong as a lever. And then, of course, the class 3 lever. In this scenario, I've got a fulcrum, I have a force, and the work is done out here. We've heard since dental school days the jaw is a class 3 lever. So let's look at that. We've got a fulcrum here, we have a force here, and the work is done out here. That's our class 3 lever. It is the weakest of the lever systems. That's why we like the jaw to be a class 3 lever. Hopefully it's strong enough that it'll chew a roast beef, but not so strong that we tear the teeth up. So that's the reason that we would prefer to have a class 3 lever. So there's a relationship between the condyle, where it fits in the skull, how the teeth touch, and the muscles that operate everything. So let's look at this. I can increase the load on the teeth by moving contacts more to the back. And when I do that, I reduce the load on the joint. So let's think about this. If I've got heavy back tooth contact, as this muscle contracts, the condyle cannot put as much force into the jaw joint. Now let's take the reverse of that. I decrease the load on the tooth by moving contacts more to the front, like an anterior deprogrammer. And in doing that, I increase the load on the joint. So here you see back teeth are open and anterior deprogrammer, because nothing back here touches. As this muscle contracts, the condyle has got to put more force in the skull. Just by chance, today I saw a patient, and she was having some TMJ issues, some acute pain issues. She had gone to a dentist, they made a splint for her, and all of her posterior occlusion was wide open, and the only place she contacted on her splint was in the front. And her complaint was that since she got this new splint, she's hurting worse, more than she did than before. Well, it makes sense, because she's got a derangement in the joint. No back teeth are touching. As this muscle contracts, this has to put more load there. It's got to hurt more. Now then, this is me and my lovely bride. This is date night. You got to admit we look good, right? So Leslie does not have a disc in one of her joints. It is completely gone and obliterated. Is there ever a time that I want the condyle not superiorly seated? And the answer is maybe so. That's what myocentric is all about. With myocentric, you take a neuromuscular bite, you tend the muscles, you take a bite registration as the mandible goes through an arc of closure. But as what we know is with a neuromuscular bite registration, always, 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 the pterygoid muscle is contracted. As the pterygoid muscle contracts, what happens? The condyle goes down and forward. So one of the things that neuromuscular people brag about is the fact that their bites are more powerful. So that must be what we need. Well, no, that's not what we need. I don't want the bite more powerful. I want it less powerful. Why is it that a neuromuscular occlusion becomes more powerful? Well, the reason is that the condyle comes down and forward from its superior position. It is no longer the fulcrum. So when it is not the fulcrum here, it becomes this most distal tooth that becomes the fulcrum. When that occurs, you have changed the jaw from a class 3 to a class 1 lever. That's why it's more powerful. So just keep that in mind. Is it ever appropriate to have a neuromuscular myocentric occlusion? And the answer is yeah. And the answer might be for somebody like my wife. In her case, she's going to be treated to a more open vertical dimension. She has to be because her condyle is down and forward. If she loads it to a superior position, she doesn't have a disc, and it was painful. So is what we did for her is we did splint therapy for about a year and a half. She became stable. My orthodontist then orthodontically brought her occlusion together to hold her in that position. And now she wears a splint on an as-needed basis. But we understand that indeed that changes her vertical dimension. So as we go through this restorative sequence in the lab on the study models, we considered the global diagnosis. We got to manage the joints in the airway. We've got our models mounted to CR. The next thing we ask is, where does the upper incisal edge go? And we base that purely on aesthetics. And remember what I've already said, we start by measuring the tooth width. Once I have that tooth width, we start to establish the length based off of that. I want the length about 25% longer than the width. So in doing so, that can help me establish how long should the tooth be. But now I've got to ask the question, where should the incisal edge go? Because maybe lengthening that brings it down into the face too far. So maybe the gum has to go up. So maybe we have to consider crown lengthening and orthodontic intrusion. That becomes the thing that we have to figure out. But after we've gotten an understanding for where that incisal edge goes on the upper anterior, I now get the lower anterior incisal edges coupled in parallel. And what I mean by that is I simply get the lower incisal edge where they contact passively against the lingual of the upper anterior teeth. Now, this is the big question you've got to ask at this point in your diagnostic workup, and it's this. Does this person need full arch reconstruction? Here's why this is so important. If I've got somebody that's got severe wear, anterior, posterior, generalized severe wear, typically those patients are going to appear that they may have lost some vertical dimension. In that case, I might choose to open them because I am going to restore that arch anyway due to the significant occlusal wear. See, I've got to be careful. I don't want to open vertical dimension if all of those teeth don't need to be crowned. So I've got to ask the question, does this person need full arch reconstruction? Because if they do, that gives me some leeway to do some different things. In this case, I'm going to get my incisal planes parallel. And then once that's done, you see, I've done my wax up. I start to get coupled. I can now ask the question vertically, where do I need to be based upon the facial perspective, the perspective of the tooth length, whatever we might need to do to get it right in terms of aesthetics and in terms of function. And that's why the next step is I have to evaluate, are we going to make a vertical dimension of occlusion change? Now, like I said, I don't want to alter VDO if they don't need all of those teeth restored because I don't want to go and do a bunch of stuff to beautifully virgin teeth. But if they got heavy, severe wear, then we've got the freedom to do that because often we're restoring those teeth anyway. Here's the nice thing with severe wear. There are two primary kinds of wear. One of the most common kinds of wear is generalized wear, anterior and posterior. In those situations, often we will alter VDO to restore the teeth. If I have patients that just have heavy anterior wear and the posterior wear is almost non-existent, you see this with deep bites, with class 2 patients, that kind of thing. Typically, I'm not changing vertical dimension. Instead, those are typically orthodontic cases where I'm doing some intrusion in the anterior segment, but I'm not altering vertical dimension with restorative changes. So keeping that in mind, I want to share two cases with you that make a very important point about changing vertical dimension. The first one is we've got to understand what is occlusal disease. So I can have dentin exposure, I can have loose teeth, I can have fremitus, I can have joint issues. There's just a host of things. But one of the things that can be a sign or symptom of occlusal disease is changes in vertical dimension. And here's the thing. Vertical dimension, while typically you super-erupt to maintain a constant vertical dimension of occlusion, the reality is some people do actually lose vertical dimension height. How do they do that? If the wear rate of the tooth is greater than the ability of the tooth to super-up to compensate for that, then you can lose VDO. So that becomes a thing we've got to figure out. Now, I told you I want to share two cases with you. Years ago, I actually published an article on this, and I had to come up with something that made sense to me. You've got to remember, I'm from Oklahoma, and I'm a pretty simple-minded guy, right? So there are two very distinct types of occlusal patterns that we look at. And the two extremes of those patterns are what I call cows and gators. This is somebody with cow occlusion. These patients have a very flat angle of disclusion. The reason is they've worn their teeth flat. They can have dentin exposure. They tend to have a really heavy force and all of these other things that you see listed. They can have that. At the other end of the spectrum, there's these people. These are gators. If you ask a gator to go side to side with their jaw, often they can't even do it because their bite is so deep. They just get so locked in. And it's real common to see this in deep class 2 patients. So they can still put a lot of force on things, but they tend to vertically load things more. So let's keep that in mind as we look at a couple of cases. So this is a lady on the upper left here that presented to me, and she wanted her teeth redone for aesthetic reasons. And I want you to notice that on the lower right here, we have got a 5-unit bridge going on. Not only do we have a 5-unit bridge, this abutment on the bridge here is endodontically treated. So we got a lot happening here. Now, this was many moons ago, and in my practice, implants were just starting to happen when I treated her. Her husband is a neurosurgeon, and he said, Dr. Fling, no implants. He just, for whatever reason, he didn't believe in them. Well, let's keep that in mind as we go forward. Let's take a look at this guy. He wanted to be restored. He wanted to look prettier, and he wanted some teeth to chew with. So let's look at these two cases. Here she is. These were her crowns that she wanted to be improved aesthetically. And I did all of the things that we talked about doing. As a matter of fact, I think back on this. This was one of the very first cases that I did after I joined Dr. Lockard's practice almost 30 years ago, or actually it was 30 years ago. In it, I wanted to show them how wonderful I was. I did my preparations. She had a large composite core. She had an endodontically treated tooth with obviously not great ferrule effect. On the lower anterior, I did feldspathic veneers. Now today, I get it, we'd do something different, but that's how I treated her back then. I did not change her vertical dimension of occlusion. With that, I was able to treat her in segments. So in this case, I did the upper and lower anterior segment first. The day that I put, here she is in her temporaries, and as we now go from temporaries here into final crowns, the day I put her final crowns and the anterior in place, I then was able to go and start to prep the lower posterior, because I was taught to treat the lower anterior, the upper anterior, the lower posterior, then the upper posterior. So now I seated the veneers down here, and you can see I have now restored the lower posterior with her crowns. Notice that I have a 1, 2, 3, 4, 5-unit bridge. I then went forward and treated the upper posterior. And the question I would ask after we've got all of this done is, did I hit the bullseye or did I waste your money? And I got to tell you, this made me nervous, but the question is, did it hold up? Let's go forward. As we look at this gentleman, I realize I can't get feedback from you. The thing I'd like you to consider, is he a cow or a gator? And I would tell you that when I do this live with people, I typically get some people saying, well, he's a cow. Some say he's a gator. The reality is it's hard to know because he doesn't have lower anterior teeth, right? So once again, this was back in the days with Dr. Lockard, because when we did our diagnostic wax up, this was actually done with white crayon. That's what we used. And so I did my wax up. I prepped the lower anterior first. Porcelain shoulders weren't even happening yet. They were just beginning to occur at this time. So I was nervous. I didn't know how they'd hold up. So instead I did a metal margin. So here was his lower bridge. I then prepped the upper anterior teeth. I got him provisionalized. We got his crowns in place. You can't see it, but hanging off of this kind of back at the angle here and back here, he's got non-rigid, or rather ERA attachments. So I'm sure many of y'all remember those. And then he had a partial that we were going to use on the upper posterior. So he wore these these crowns for a period of time. He comes back in a couple of months later, and he has fractured the porcelain off of this upper incisor. Now, we all have to know who we blame for this, right? This has to be the technician's fault. It couldn't be mine. So we remade the crown, and then he broke this central. We remade it. He then broke a lateral off at the gum line. He ended up breaking another canine. Absolute true story. Now, here's what I realized. Look very closely. Notice that where the porcelain broke here, I still see opaque. What that tells me is that is a mechanical failure. That was not a debond of porcelain, the feldspathic porcelain, to the opaque in the metal. But here's a bigger clue. Look right there on the lingual of the crown that I put right there. See that indentation? That is where the lower incisal edge indented the metal. So here's the lesson that I want to give you. It's not if you're a cow or a gator that matters. Everybody's got a pattern and they do what they do. But if you put something in the way of the pattern that that person has, and if their muscle force is strong enough, they can tear it up. What I did on him is I got this in the way of what he did. I made the lingual such that I violated the movement of the lower jaw. Now, I can utilize changes in vertical dimension to help me overcome situations like this. And that's why I wanted to bring that up. The lady with the 5-unit bridge, that was done many moons ago, and that 5-unit bridge is still there. So I just got lucky. She simply doesn't put enough force on her teeth to cause it to fail, even though she has a 5-unit bridge. She doesn't have the parafunctional activity that everybody has. But here's the lesson that I want to give you. Never steepen angle of disclusion. Okay, now, when I talk about angle of disclusion, let's get into this just a little bit. We always begin by simply looking at the face. And when I look at the face, I'm asking the question, would that patient be improved from an aesthetic perspective if I change the distance from a point on the nose to the chin? In other words, if I altered the vertical dimension, would that person look better? It's a very subjective thing. You see people like this. They're so close, they've got a very negative smile line. I call it bitter beer face. It just doesn't look great. So as I'm evaluating vertical dimension, I've done my global diagnosis and I've looked at the distance from here to here, and I've asked, is that 1-to-1? If it's not, then I have a consideration for changing VDO. The next question I do is I ask the question from a facial perspective, would that person be improved if I changed that dimension? So keeping that in mind, there now are 3 restorative determinants of vertical dimension. We've already talked about the facial aesthetic one, but there are 3 restorative determinants as to why I might alter vertical dimension. So let's go through those just a second. The first one is this. I may want to alter incisal edge length or position. Okay, so let's think about this. Somebody doesn't show much tooth. Remember what I said, what I do on that guy. I got something in the way of what he did. If I lengthen an incisal edge and they've got heavy parafunctional activity, I'm now going to put something more in the way of what they do. It's going to fail. So I can open the vertical dimension, and now it doesn't get in the way of me lengthening the incisal edge. So that's one of the reasons I might alter vertical dimension of occlusion. The other consideration is I just don't have room. I've got so much heavy wear that to get my preparations done and have the appropriate material, I just don't have the space. So I've got to open vertical dimension to give me room. And the third reason is the one that I think is the most critical. And it is that I might want to alter their angle of disclusion. Said another way, I might want to open the vertical to give me space to get something out of the way. So that's the importance of doing that. By the way, this is one of the reasons that I get our young kids to the orthodontist at an early age. You know, back in the day, what would we do? We'd have crowded teeth. They would take premolars out. You had have excess space, and now the teeth would be retracted to close the space. Well, when that happens, what are you doing? You're deepening the bite. You steepen that angle of disclusion. Now, as the patient goes through parafunctional movement, it's not when they're 17, 18, 19 years old it's a problem, but when they're 48, 49, 59, 69, they've worn the heck out of those teeth, that's when it's a problem. So I never want to steepen angle of disclusion. So here's what I mean by angle of disclusion. It's the angle that the lower incisal edge tracks against the lingual of the upper anterior. Okay? So that's one of the reasons I might change VDO, because when I gain space, it gives me the opportunity to alter this angle or to dish this out more to get something out of the way. So it gives me more space. Here's an example. This is a patient that presented, and he had an upper bridge that he broke. So I made a provisional for him, and here is his provisional. Look at the angle on the lingual of his upper canine right here. See the steepness of that. I was worried about it because he has got canines and one central here that's an abutment. And if he fractures this canine, we're out of luck. He had some old crowns back here that he wanted to have redone. It then gave me the opportunity, because we were going to redo posterior crowns also, it allowed me to change his vertical dimension of occlusion. When I opened his VDO, that gave me the space to flatten the lingual of this canine. So now I have flattened this angle of disclusion, or said another way, as I open him, it gets this out of the way of what he does when he goes side to side. So it takes some of the functional stress off of that, or parafunctional stress, I should say. So there are a number of reasons that I might change vertical dimension. Like I said, one is I want to change incisal edge position or length. From a functional perspective, I might want to change angle of disclusion. And the third reason is I just need space. So those are my considerations for changing VDO. So let's ask the question, what is VDO? And it's really pretty simple. Is all VDO is, it is an equilibrium between tooth contact position and muscle length. That's all it is. You've got the masseter muscle, and the masseter muscle is one of your contracting muscles, right, to close the jaw. It's the equilibrium between that muscle length and the tooth contact position that establishes your vertical dimension of occlusion. So keeping that in mind, let's ask the question, how does it all happen? I can have somebody like this. They've got a very angled jaw. So as they grow and develop, they have a short ramus. And as they grow and develop, you end up getting super eruption of the lower anterior segment or super eruption of the upper anterior segment to compensate for the open bite due to the short ramus. So is what you end up with is scenarios like this. You often see uneven occlusal planes. You see it all the time. Here's the lower posterior occlusal plane, the anterior occlusal plane that's super erupted. You can bet that this patient is probably class 2. We also get people that look like this. They've had super eruption of the upper anterior segment, and they can have the real gummy smile. Now, on the other end of that spectrum, I can have somebody that's got more of a square jaw or a long ramus. In this scenario, these people tend to have really heavy masseters. They tend to have significantly more heavy bite force, and they have what I call bitter beer face. They've got this scenario where they get that negative smile line, and facially, when you look at them, it just feels like it would look better if they were more open vertically. Now, as it turns out, it's these patients right here that tend to have generalized wear everywhere. So often you're restoring all of the teeth anyway, so altering that vertical dimension sometimes it works out to be okay. Now then, let's talk about some misunderstandings of VDO. First of all, we cannot use a patient, whether they're comfortable or discomfort, as a determinant of their VDO, because here's the thing. You can open somebody well beyond what is considered a typical VDO, and they typically get along with it. It's just not a painful event. If you open somebody too much, typically is what happens is a slow intrusion of the teeth. Or if the force is strong enough and you don't get intrusion, depending on the parafunction, you could damage the abutments, the teeth, the crowns, whatever it might be. But typically, opening somebody too much is not a painful event. The other question that is always asked is, does altering VDO affect the TMJ? And I think it's important to understand a few things about that. I've got a condylar fossa, a disc, and a condylar head. The condylar head is round. So as we open them vertically, because this is round, it doesn't change the load that it puts on the disc here. Now, I'm telling you that, and of course, what I'm saying here isn't true at all, because we know that the condylar head here is not round at all. We know instead that you've got a condylar fossa, a disc, and a condylar head. And the condylar head actually has a medial and a lateral pole. And we also know that it can be very irregular in shape. So when I alter vertical dimension by opening them, is what happens is where the condylar head puts force on the disc, that changes. So what does the research say? And it says this. If I open somebody's VDO and they've got a derangement in the joint, I might make that person worse. However, if I open them and they've got a joint derangement, I might make that person better. Because what have I done? I've changed the position of where the condylar head puts the force on the disc. So if I've got a derangement, the thing you've got to do is test it to find out. Now, let's look at some other considerations. What about the muscles? How do they handle all of this if I change vertical dimension of occlusion? And here's what the research says. If I alter VDO, resting EMG muscle activity goes down. So let's think about that. I've got a heavy gritter and grinder. I'm going to open vertical dimension. As I open them, the resting muscle activity level goes down. That's a good thing because now we don't put as much force on the teeth. Hip, hip, hooray. However, in about 90 days, these people are back to their pre-treatment muscle activity level. Okay, now the resting muscles, not such a big deal. What about the functional EMG muscle activity? That's the one that concerns me more. Here's what the studies say. When I open vertical dimension, those muscle activity levels go up. So again, let's think about this. I'm a heavy gritter and grinder. I've got generalized wear everywhere. Dr. Fling said, hey, I got short teeth. We've got wear everywhere. Let's open vertical dimension, give longer teeth. But guess what? When I open VDO, the functional muscle activity level goes up. I don't want that because now that puts more force on the teeth. So what do I do? And the answer is you wait it out, because in about 90 days, you revert back to pre-treatment muscle activity levels. So with that in mind, here's a test question. How long do we test somebody when we alter vertical dimension of occlusion? And the answer is at least 90 days. Okay? So for me, when I fee out a case where I'm changing vertical dimension, my fees for that are different than when we're not, because it takes a different level of care, skill, and judgment. So keep that in mind. So at least 90 days. This is an interesting study. Is what it showed is when we go from centric occlusion to centric relation, on average, you can have about 1 millimeter of vertical seating of the condyle in the fossa. Now, depending upon the length of the jaw, is what that means is you kind of get an auto rotation of the jaw. And so you can gain anterior space without changing VDO at all. So that's just another great reason to treat people to centric relation. Now then, I often will end up placing lingual composites to create my anterior coupling. I might do this post-ortho. If you're going to do lingual composites to get your coupling right in here, I don't want to fill my composite into this area here where I could interfere with their envelope of parafunction, and I sure don't want to take it from here up to where I can change the angle of disclusion. I've got to keep it out of the way. So if I do these lingual stops, it's just on the incisal edge. I don't want to get it in the way of what they do. So here's the test question of the evening. What is the determinant of VDO? And the answer is it is the contracted length of the masseter muscle. How do we know what that contracted length is? And the answer is you don't. So then how much do we open someone? And here's the answer. This is your take-home message for the evening. You open them as little as possible to do what you need to do. You open them as little as possible to make them more aesthetic. You open them as little as possible to create a less steep angle of disclusion, to give you the restorative space that you need, whatever it might be. So that becomes the answer, and then we're going to test them for at least 3 months. I want to share with you briefly a case that I'm in the process of treating right now. This is a lady that is being treated by a dentist up in Tulsa. They're about an hour and a half away from us. He is redoing a bridge on the lower because the patient is wearing holes in the second molar crowns, and he's puzzled as to why it occurs. And so before he redid the bridge, he wants to understand it. This is the lady's centric occlusion. This is the bite with her case mounted in centric relation. That is a huge discrepancy between centric occlusion and centric relation. Now, let's take a look at this. This was her cone beam. This is her eccentric occlusion. Look how down and forward her condyles are in the fossa. They're way down. So is what happened for her is I took a centric relation bite record and I made a splint for her in centric relation. This is her cone beam in centric relation. Notice we're still maybe not all the way up superiorly, but man, what a difference. There she is. And that's with their splint in place. Start to notice how class 2 she is in this position. So the thing you've got to ask is what happened? And in her case is what happened is she was orthodontically treated with the condyle down and forward. They move the teeth together. She stays down and forward. I'm putting her in a splint to get her comfortable because she wasn't comfortable in that protrusive position. So now we've got to figure out where in the heck are we going to put her? And if it's going to be in a central relation position, she's probably going to have orthodontic surgery to correct it. Well, that's a big deal, and I don't know that she'll want to. So we've got to be careful because as we open somebody vertically too much, the condyle will go down and forward and you will open the vertical dimension of occlusion. The reason her back molars are wearing and getting holes is the muscles are trying to get the condyle superiorly seated. The back teeth are in the way and she wears holes in them. So that's the story of what's going on with her. So I've got to keep that in mind when I look at VDO. So we evaluate VDO, we then get the lower plane of occlusion level from front to back and side to side, and then I simply then coordinate the upper posterior to the lower posterior, and that's how we do our diagnostic wax up. Now, is what I want to do is have you understand that as I'm waxing this stuff up, as I'm working these cases up, there's great ways to cheat. At the Institute, I do a waxing course that if you want to learn more about it, but it's what I do is I teach you how to cheat with the rapid waxer. So as I'm waxing these back teeth in here, I'm not waxing all of these teeth up hours at a time. I'm simply cutting the plaster down and adding a tooth very quickly with my rapid waxer. So keep that in mind. We keep a inventory of these wax teeth. We keep different electric waxers to do our things, and it really makes that whole process pretty simple where we can just get these teeth and add them on quite quickly. So when you're doing these wax ups to change vertical dimension, another technique could be, in this case, the occlusals of her teeth look pretty good. As you can see here, I simply sectioned this. I've added some rope wax in here, reseated the teeth where they're down further at the more open vertical, and then added wax to create the axial contour, and that's how I open the vertical. So, make life easy for yourself if you're doing these wax ups where it can be in a way that it doesn't just drive you totally insane. So keeping that in mind, I want to share with you a few thoughts. Clinically, when we go to the mouth, there's also some steps that we follow. We've taken care of the global issues that are there. We've gotten the joints happy, whether that's through splint therapy or equilibration or whatever that might be. And now the next thing we do in the mouth is if we open vertical on our diagnostic models, then of course, as we start to restore them, we've got to open the bite clinically. So the question is, how do we do that? And here's what we do. I start by placing composite on the upper premolars. So notice the lower buccal cusp tip of the first premolar goes into this composite here and here. That is my vertical stop. How much do I open them? About the amount that I open them in my diagnostic wax up. It's a guess, people, but you made the guess based upon the aesthetics, based on the restorative space that you need, based upon the facial perspective that you looked at, but it's still a guess. So I've gotten my vertical stops on the premolars. I prep the upper anterior and I make those provisionals. I do the lower anterior and I do those provisionals. I get the coupling adjusted on the lower incisal edge against the lingual of the upper temporaries, and I make sure I can go back into my premolar stops. So that's my reference for where I go vertically. After I got my upper incisal, then I'm going to parallel the lower incisal plane to that, and I'm going to get coupled in my temporaries here, and I'm going to go into my premolar stops. Now that I'm coupled in the anterior, I can now prep the lower posterior. I can get that temporized to where my occlusal plane is level, and then after that is done, I simply coordinate and prep and provisionalize the upper posterior to meet against the lower posterior. So that's the sequence of what I do as we provisionalize a case where we're changing vertical dimension of occlusion. We do upper and lower anteriors, but we put premolar composite stops to reference us vertically before we do that. Once we get that coupling in the incisal, now I can do the lower posterior and then the upper posterior. So that's the sequence that we use. So keeping that in mind, I'll share with you very quickly again. This is a case where this patient was referred to me by my specialist. She had already initiated treatment with another dentist and they had some issues. Here you see some aesthetic crown length and we do wonders for her, but she was going through a lot of stuff health-wise and we were just trying to get her more stable. Notice here she is with her old crowns. In this case, I could only make one composite stop because she didn't have any teeth on the other side. So I manipulated her into central correlation. Here's her composite stop that you see right here. After I had the composite stop, I cut off her old crowns. I get my preps cleaned up. I provisionalize those. The lower anterior is all I did here is I just equilibrated her. You know, the beauty of patients in my practice, the average age of a patient in my practice is about 104. So their pulps are usually down to about right here, so you can do whatever you want. I just equilibrated the lower incisal edge to get it level and to look nice. Here you see my composite stop. Now I'm going to do my upper anterior provisionals. I start to get those shaped. I get my coupling that you see right along here. Now that I've got my anterior coupling, I can now go back and do the lower posterior. We're going to end up with some more implants down here one day. And then I do the upper posterior. And that's how we register the bite. Here she was in her final crowns, or at least anterior crowns. Not important, but the thing I want to point out is how we registered that with the vertical stops and the composites to get her bite. I want to share one more case with you because it really points out vertically how we can use this to our advantage. This is a gentleman that presented to me, and he was about to leave for a 2-week safari. And he had mobility in this bridge here and here, and he wanted a new bridge. Notice that he's got heavy dental alveolar extrusion. He's got short clinical crowns. He's got a really deep bite. Here you see the lower incisal edges of these teeth literally go up into the lingual of this and actually touches soft tissue right here. So he's got a very deep bite. And as what's happening, as his jaw is going through parafunction, he's literally mechanically knocking this bridge out of his mouth. So that's what's cooking on him. I've got to get him fixed before he leaves to go out of town. So I get my diagnostic models, and in this case, here's my diagnostic wax up. Notice I have a much longer upper front tooth. How did I do it? I did it by opening its vertical to give me the space that I need to give him a longer tooth. The other advantage of doing that is that by opening the vertical, it allowed me to lessen his deep bite and to decrease his angle of disclusion. Or I was able to change this to get stuff out of the way that I don't want in the way. So here he is. I prepped. These came out almost with my fingers. They were so mobile. He had huge bony defects up here. I made a splinted provisional bridge that went from here to here. And, you know, I was just trying to get him some stability before he left town. I thickened it up back here, hoping it would last. Somehow it did. I did some radius surge to expose these teeth so that the orthodontist could get brackets on those teeth, and now they start their intrusion. How much do we intrude? We intrude to get the free gingival margins heights leveled. Now, today, I wouldn't treat him like we did. Back then is what we ended up doing. This was before bone level fixtures even existed. So these were Straumann tissue level. Obviously, we did custom abutments to get the margins up, so we didn't have the cement margin very deep. Here you see the intrusion of the lower anteriors with free gingival margins that are level. Today, if I were treating this case, I would treat this with composite bonding down here. I would either do that or veneers, but probably with composite bonding. Back 15, 18 years ago when I did this case, I did full coverage crowns. Hardest crowns there are to do. Well, second hardest. Single front crown's probably the hardest. But here you see me getting visualized. There you see his customized abutments, and then we get the crowns in place. This is Gary. Gary's still in the practice today. Everything's held really well. The key to my success with him was opening the vertical so I could decrease this angle of disclusion so he doesn't mechanically beat these teeth out of his head. So that was the trick to taking care of Gary and getting him fixed. So here's the deal. I often will rob Peter to pay Paul. In this case, notice I have a lower incisal here. I can either equilibrate to shorten this incisal edge or orthodontically intrude it to bring it down, which is what we did on Gary. And I can alter the vertical to diminish this angle of disclusion, or so that I can change the lingual of this to get stuff out of the way. So that becomes one of the primary reasons that I will alter vertical dimension of occlusion. As we close here, I do want to tell you there is one other way you can help determine vertical dimension of occlusion. I do another course called Treating the Severe Wear Case, and this is one of the primary cases that we use in that course. It's a hands-on course we do through the Institute. This is a gentleman that's got a lot of heavy wear. If I were treating him today, knowing what I know, hands down, this would be an orthodontic case. He's lingualized here. He's, if I orthodontically got these teeth moved out and intruded, it would be so much better. Back when I did this case, it wasn't on my radar. But it's what he had was heavy parafunctional wear. You can see how he went into crossover and all of this fit together. Now then, it's what you do is you mount your models to centric relation, you take a protrusive bite record, and you set your condylar inclination. Now that the condylar inclination is set, I raise the pin off the table. I now go through my parafunctional movements with lab putty on my table. As what I'm creating here is a parafunctional guide table. So now I can trim this back and you can see what's happening here. As the patient goes into lateral excursions, it's going, and boom, there it is in the crossover into that area right here. Here it is the other direction into crossover. Here's protrusive, and there's everything in between. This is the parafunctional guide table for this person. Remember what I said, I never want to get anything in the way of what they do. So now is all I do is I wax up the upper and the lower anterior teeth to what I think is right. Now that I have the anterior teeth waxed to what I think is right, I go through my parafunctional guide table. If the shapes of the teeth are allowing the pin to come off of this parafunctional guide table, I have now violated his envelope of parafunction. Or said another way, I've created shapes of teeth that are going to get in the way. So now is what I can do is drop the pin on the articulator, which opens the vertical dimension. It now allows me to change the contours on the lingual of the uppers against the incisals of the lowers to get it out of the way where the pin does not come off the table. So this is a tool that can help you understand vertically how much can I open somebody, and then we go through the same process that we just talked about. I prep the anteriors, I use my composite stops after I get the upper and lower anterior provisionals set. I can do the lower posterior, then the upper posterior. He's going to wear these temporaries for at least 3 months, and now I can transition those temporaries into permanent crowns in whatever sections or time frames you would like to. We get our various models, we get the crowns done, you get them in place, and life is okay. I still think this would have been much better off as an orthodontic case, but still it turned out okay, and it's held up very well for many, many years. So that, in a nutshell, is what I wanted to share with you tonight. At the end of the day, when we consider vertical dimension, there are the restorative determinants that we have to keep in mind. We might change vertical for incisal edge position. We might change it because we need space, but most importantly, I'll change it because of angle of disclusion. If we alter vertical dimension, we understand that we never want to do it so much that the condyle is coming down and forward to where it's in a translation perspective. Because if we go down and forward, we're no longer in a centric relation position. We've now created that class 1 lever that'll be destructive.